everyone, welcome to Digital Health News and welcome to this episode of DHN CXO podcast. Now, for those working in digital health, C-DAC is a familiar name. C-DAC, which is Center for Development of Advanced Computing, has been the engine behind India's digital health journey. Whether it is powering hospital systems with e-Sushrut, enabling millions of teleconsultations through e-Sanjeevani, or driving standards in health informatics and interoperability. Today, as India builds its national digital health stack, C-DAC's role is more critical than ever. Today, I am joined by Mr. Praveen Srivastava, Senior Director and Scientist at C-DAC, to explore how their work is shaping the foundation of a truly connected healthcare ecosystem. Thank you so much, Praveen ji, for being part of this conversation.
Thank you. Thank you, ma'am. Thank you for inviting me here for the podcast and sharing the views and vision of C-DAC in health informatics.
Let me first start with my first question, sir. CDAC has been a silent yet powerful force in India's digital health journey. How would you describe CDAC's role in building the foundation of India's digital health stack?
See, if you at present, if you go through the C-DAC's health stack, it's starting from standard to implementation to licensing. So we are in every space of that, almost every space of the health journey. We are in the implementation through our e-Sushrut software in hospital. We are digitizing health hospitals. We are in teleconsultation as e-Sanjeevani. It is one of the biggest teleconsultant in the world. We are also focusing on the standards so that interoperability between the two health systems should be there. Along with that, what we have done is that we have channelized the drug supply chain through our systems. All procurement, almost in central government and state government, all free drug distribution from is done through our system, starting from procurement of the drugs to the dispensation of the drug up to the final patients. So this is done through our system, and we have touched patients life, citizens life, through our e-Rakta system, which is adopted by Ministry of Health and Family Welfare. It is incorporating all blood banks in one system, and it is giving you the status of the blood availability across India in various health hospitals. So if you go through that C-DAC's work in health informatics, it is starting from the standard. We are defining the standard. We have participated in the various standards discussion. Our C-DAC Pune team is expertise in that. Noida team is in health informatics product research and development and implementation, rolling out. Mohali team is doing e-Sanjeevani. So if you talk about whole C-DAC, it is all plethora of systems which we are doing. So, and another thing is that we are partnering with National Health Authority. We are partnering with other state ABDM systems, ABDM and Ministry of Health and Family Welfare for their providing digital solutions to their program and reaching out up to the lowest level in the hierarchy of the digital health.
That means that CDAC is creating 360 degrees and holistic solutions, not only
Correct,
for the
correct.
central but also for the state ecosystem.
Correct. If you see that, we are also working with CDSCO, which is basically providing licenses for drug licensing. We are also
Yes.
working with NPPA, which is basically fixing the pricing of the drugs. So from licensing to pricing to implementation, and we are working with many aims for doing the health research also. We are working for the natural language communication in most of the Indian languages. We are working to develop such a system which can communicate in the Indian languages.
That's absolutely fantastic. Praveen ji, one of the landmark project of C-DAC is definitely e-Sushrut, HMIS, that has been deployed at scale across AIMS hospitals and thousands of hospitals. Uh, I wanted to ask you, how has it evolved over the period of time? And what is the significance of the new initiative, that is e-Sushrut clinic initiative for smaller providers?
So it's a long journey. So we started in 1998 with SGPGI Lucknow. Through your podcast, I want to thank SGPGI for giving the domain to us, and we acknowledge them. So we started with SGPGI Lucknow. From that 1998 onwards, we have slowly but steadily built our systems. Earlier, it was a client server architecture system. Then we have gone to browser based system. The best thing which come here is the 2004 2005, when we have gone to MGIMS Sevagram, where it was sponsored by Ministry of IT project, and Ministry that MGIMS Sevagram has given more domain knowledge, and from that onwards we have gone to PGI Chandigarh, and then we have gone to statewide deployment. So our single source of the single system has gone to multi-instance system with participation of the Ministry of Health and Family Welfare, and state. We have gone for statewide deployment, and by 2014-15 we have gone for various statewide deployment. After that, in 2018, with so many government initiative, that plenty of aims is being opened, and they have participated in clinical activity in the for public. So we for aims journey, our aims journey started in 2018 with aims Patna. So aims Patna, we have installed the software, and Ministry of Health and Family Welfare and has noted the success of the aims Patna instance of the software, and they asked us to deploy the system across all aims, new aims. And this is very economical system, very small money just for maintenance of the system, just that it's a peanuts of money. If you talk about the HMIS systems width and length, it's a very small money, and we initiated with all the support of all aims. We have developed a software which is basically taking care of the needs of aims, and we have those consultants of aims has contributed in enriching the e-Sushrut software. We have created a vertical of the different e-Sushrut. So in 2020, Indian Railways has trusted us for rolling out of the e-Sushrut HMIS system in all Indian Railways hospitals. So right now, it is a complete Indian Railway hospitals on e-Sushrut HMIS platform. So what has happened is that we have categorized our e-Sushrut HMIS in three major domains. One is a state vertical. We are currently serving 11 states in India, and we have a AIMS vertical and super specialty vertical software which is serving to AIMS, PGI, JIPMER. We have recently, JIPMER has trusted us. We have just initiated deployment of the HMIS software. Third vertical is PSU's software, that is Indian Railways. Those hospitals like SAIL has three hospitals. So NHPC has 22 health clinics. So we have categorized these three verticals, and a separate instance of e-Sushrut has been created. Very recently, CGHS has trusted us, and we have that has also come to e-Sushrut HMIS platform. You have talked about e-Sushrut at the clinic. What has happened is that we have achieved almost, we have gone to almost every super specialty vertical, 11 states. So it has gone a very good amount of hospitals, health facilities. But what has happened is that there is a lowest level, the single one clinic, two clinics are not digitized. So a national health authority has trusted us, has seen the system and trusted us that okay, this system can be, if it is a standard system following the various standards and ABDM milestones, then this system can be proliferated to the lowest level. And it's a very small, it's a very small amount will be there, say rupees 300 rupees, 299 rupees per month. So that was C-DAC's initiative with the help of NHA. In, you can say that NHA's initiative, where C-DAC has joined NHA to penetrate digital health up to the lowest level, so that a complete health ecosystem can be built where all entities of health vertical can participate in a digital health journey, and with a minimal cost. So that was the where we have gone for e-Sushrut at the red clinic.
Absolutely. I mean, as they say, your digital health ecosystem is as strong as the lowest common denominator in that entire health ecosystem. And I think our primary clinics and small clinics and rural facilities are the ones who need to be brought into the digital health ecosystem. Beyond metro cities, beyond tier one cities, we need to go dig deeper and bring those uh, primary clinics and the rural facilities onto the mainstream and digital health ecosystem. Now, Praveenji, one of the biggest challenges that generally is faced by organizations like C-DAC is sort of convincing these small clinics and rural facilities to bring them into the digital ecosystem. So, how is C-DAC ensuring the affordability? You already mentioned that point, but if you can just elaborate on that. How is C-DAC ensuring affordability and ease of adoption while maintaining the standards and interoperability?
So what we have done is that first and foremost is for any software, if anybody is adopting, we are informing them that there is a value in it. You adopt this, and what has happened is that with digital health incentive schemes, which is NHS scheme, they are being incentivized for using digital health. So with NHS effort, NHS incentives, they are seeing the system as a value added system. They are seeing the value in it. Doctors are seeing value because they have been given a system where it's a very simple system. It can reduce their prescription writing time. It is reducing their clinical errors, and it is giving patient value that they are taking digital prescription, where they don't need to recognize the doctor's handwriting. And what we have done is that generic prescriptions are being generated, generic drugs are being generated. So this is one way of convincing the end clinic that you are getting value in it. Another thing is that you are participating in government of India's initiative. Your contribution is for government, for India, for creating a good value chain for digital health. A strong help desk team, a regular comprehensive capacity building. These are the regular exercises. So there are three aspects: value addition is there, help desk is there, and capacity building is there. So that if there is any problem, it should not happen that they are there is a problem and we will not use. There is a problem, the solution is there. You talk to us, get the solution, use it. And fourth point is that everyday upgradation. So any initiative, government of NHA has said that there is a M1, M2, M3. NHA has released M4. So we have included M4. So they know that the system which is being there will adopt all those initiative of government of India, so that they are well up to date. So tomorrow all these this, and some best part is that is interoperable. So patient can see their prescription and lab report on their ABHA app itself. So this is how these value additions has been created. It's a tough job, no issue, no denying, and that this is a tough job. Going to the field, encouraging the clinician. There are suspicions also. I will say there are suspicions also, but these are difficulties there, but signs are encouraging actually.
That is absolutely fantastic to hear, because we can create technology, but if there is no adoption of that technology,
Correct.
the technology fails to serve the purpose why it was created. So it is very,
Correct.
very important to create that awareness among the doctors, among the clinicians, to use those systems and also provide prompt support whenever there are
Correct.
some glitches or errors in the technology.
So that is the forte of CDAC.
Yes, yes. Let's move on to the next question. Praveenji, C-DAC has been a pioneer in telemedicine, even extending beyond India's border. Now, what impact have you seen so far, especially after COVID, and how do you see remote care solutions scaling in the next 5 years?
E-Sanjeevani is itself, honestly, we didn't expect that this will be so successful. So, E-Sanjeevani is now national telemedicine teleconsultation platform. And we are, as CDAC, we feel proud that we have participated in this type of initiative of Government of India. See, right now, this is becoming part and parcel of the medical consultation. Right now, main thing is happening is that if you are going for routine checkup, why should I travel to that doctor and wait for the doctor? We are sitting at home and we are giving the information, and doctors are creating the trust of the people, citizen, is on is coming there, because one thing is that it's a government support, so there is a no glitches in the technology where consultation is, it doesn't seem that consultation is not happening face to face. So that has helped. And in the another 5 years, I am seeing this will be, e-Sanjeevani will become part and parcel of any consultation, because in all the government, what we are seeing is that in the all the government hospitals in AIMS, everybody is thinking that whatever the hospital boundaries you create, until unless there is remote hospitals is there, you cannot manage the crowd. So in another 5 years, we are expecting that regular consultation will be happening through e-Sanjeevani type of teleconsultation system, where patients is not physically visiting to doctor, and slowly e-Sanjeevani has built that trust that okay, this can happen, there is no need for touch of a doctor. And best part is that now it is remotely, you can monitor blood pressure, you can monitor your fever, and all these equipments are there, you can monitor your sugar. So remotely you can monitor and share with the doctor, and doctor can describe all things. So this integration with of e-Sushrut, e-Sanjeevani, and other health systems is building trust in teleconsultation. And in future, managing the crowd in the hospital, patient coming for critical illness to the hospital, for regular illness it may adopt that they can go for teleconsultation, which will manage, because India is a big country of 140 crores population. So this technology will help patients to take the doctor's consultation beyond their district's boundaries, beyond their state boundaries probably, and take the consultation of the best doctors available.
Praveenji, one of the major issues that a lot of people who are developing solutions for India's healthcare, digital solutions for India's healthcare face is the problem of interoperability. How do we make sure that two different systems talk to each other in a common language, and eventually there is some kind of synchronization between those systems? Now, with NRCES, CDAC has played a pivotal role in fire and EHR standards. From your perspective, from your vantage point, tell us, why is interoperability so critical for our healthcare ecosystem, and what are the current gaps that CDAC is addressing?
Because India is say interoperability is must, because see India is a big country, and no one system can serve all the needs of a India. So there may be a multiple health systems. The basic problem was the continuum of care. So what is happening is the patient has gone to one doctor, and he has written certain consultation paper, and patient has gone to some other doctor, that their digital health system is different system, so that record has not transferred, so that both different system can talk. So CDAC has worked on, with the help of Ministry of Health and Family Welfare, CDAC has worked on developing electronic health record EHR 2016 standard, so that every health system can adopt those standards, with which has basically framed to NDHM, and then NHA has come. With with NHA coming to picture, they have done a fantastic work creating a interoperable framework, creating a consent management framework, creating a fire connector frameworks. All these frameworks has been done. There are three major milestones for ABTM: M1, M2, M3. M3 is basically interoperability thing, where can share their record from one system to another system with the consent of the patient itself. So making a complete ecosystem is that it will be something like UPI. You transfer the money from one account to another account with a click of button. So for health record, it is also required that you can click up the button with your consent, transfer your medical record. That will use retests, that will reduce the clinical error. If you are talking about, generally what has happened is that if you have not written your problems on paper, when you go to the doctor, you just forget few things which are very very much compulsory. These continuum of care will definitely help. Sometimes it happens that you are allergic to someone, you didn't tell to the clinician, and it has there is an error. There is a consequence of that error. Through this interoperability, we can manage these type of error. So this will be a unique thing when such a vast country with such a variety, you are talking from one system with its different languages. We speak different languages, and then you are talking about interoperability from one system to another system. You are transferring the data without not transferring, but you are talking to each other without any duplicity of the things. So that is why interoperability is must. CDAC's NRCS is doing fantastic job in terms of providing those technologies and capacity building to all digital health product builders. So they are coming, they are discussing with our CDAC and RCS team. They understand the nitty gritties of the standards, how that can be done, how it can be implemented. All these things are done by CDACs and RCS.
Praveen ji, we are in 2025 and artificial intelligence is the buzzword. It would be wrong if we don't talk about AI. Beyond infrastructure, C-DAC is also building AI and machine learning and big data tools like cancer analytics and outbreak surveillance. Uh, Tell us about that, and how do you balance the innovation aspect with the practical realities of adoption on the ground? Would love to hear from you about that.
So one thing is that so as you said, this is a buzzword. CDAC has also started this initiative of in indulging in AI and ML domain and doing health research. One thing we have learned is that see, medical domain, health domain is a very tough domain. So all those models will not run very purely as other, because it's dealing with the health of a patient, it's a life of a patient. So anything wrong going on will be critical. So you cannot adopt these LLM models very straightforward in the health domain. So first thing is that. Another thing is that AI cannot replace doctor, because doctors are ultimately, because every patient is different. With AI technologies, you can help assist doctors. So create assistant to doctor so that doctors can take the decision, make his life or her life simple by assisting him or her, so that they can take the right decision. CDAC's objective is to developing such technologies and indulging in such domain where we are helping clinicians to take one of the thing is that, at least in government domain, what is happening is that there are plenty of patients, and writing digital prescription is a tough. Typing, no doctors write like to type the patient. We are trying that through language, through speech, conversational AI can be adopted. Through conversation we can learn what the conversation has done. The patient is suffering, patient is saying, I am suffering from fever from the last 10 days. So fever is one of the chief complaint of a patient. Doctor has said that you are suffering from viral fever, you take dolo and do the CBC. So this is doctor has said. So this system is covering that, okay, dolo is the medicine and test is CBC. So this is these type of system which we are building so that doctor's life can be made easy. Another thing is that if you talk about the patient perspective, the doctor has written that you need to take Dolo SOS. So patient may not understand what is SOS. So another work which we are trying to do is that we are trying to literate patient through our technologies, that okay, this is how the patient, the drugs, how the medicine you need to take. Along with that, as cancer research you talked about, we have participated in the cancer mission also. We are working with those mission technologies. Our CDAC centers are doing the research on the basis of MRI and X-ray images to diagnose the type of cancer, the stages of cancer. All these things are part and parcel of the our health domain where we are working on it.
Praveenji, we have spoken about technology so far, but digital adoption is not just about technology, it's also about the people. You briefly touched upon the capacity building role that CDAC plays, but I would like you to elaborate a little bit on that and tell our audience what steps CDAC is taking to build the capacity among healthcare professionals and ensure that there is a smooth adoption.
CDEX project management and project execution is very simple. We create first and foremost, because technology is there, first and foremost is the capacity building of all those nurses, technicians, clinicians, and administrators. So these are the four verticals where we need to continuously build capacity, train them, uses the system. And how can you convince them to use the system? You can show that benefits and value of the system. So earlier we try to build, whenever we go for implementation, we try to take sessions, various sessions at the premises itself, for training them that this is how HMI system is there, this is how EHR is there, what is EHR, what is PHR, everything we tell, how they are being helped. So we have defined a very extensive course curriculum for capacity building. Okay, we are participating in various conferences, we are participating in various institutions, that this is how you can build systems. We have also wherever we get time, we talk to nurses also, nursing students also, where we can discuss about the digital adoption, why digital health is required. So it's our continued process. So once implementation is there, implementation has gone, we continue to train nurses, because these are very changing population. So new nurses are coming, new doctors are coming. So it's a continuous process of adoption, HMIS adoption, so that they can adopt the system. Best part is that we want to inform them that we are resolving your problems, we are trying to solve your problem, so that you become our partners, learn from us, and tell four more guys. So everywhere, wherever you go, we train master trainers, we inform that master trainers will be there, we educate master trainers, update master trainers regularly. This is our training activity, capacity building activity. This is one of the most part and parcel of our project implementations. So that is why we have reached to such level.
Finally, sir, what's your take on how CDAC's role will evolve over the next decade as India moves towards digital governance? I mean, we have always seen a pattern with India's adoption of technology in terms of finance. We have seen India leapfrog into the UPI system, moving past the entire credit card, phase. Uh, do you think similar trend we will also see in digital health? And from a macro perspective, how do you see your work, CDAC's work, shaping India's position as a global leader in digital health?
It's a very great question. E-Sanjeevani, you have seen that it has gone beyond the boundaries. E-Sushrut is also taking shape. There are many other C-DAC software which is basically being looked with very interest. What I am seeing is the next decade for C-DAC is that we want to give India digital public health goods which is available for going beyond the boundaries. We will be providing solutions which are of international standards and adopting international standard. Right now, DPDP has come, so this is equivalent to GDPR, and we will be adopting to that ecosystems, so that these CDEX software, all CDEX softwares are indigenous system. Every line of code is written by Indian programmers in India. So we are ready for our first job is that to create these products of international standard, and we are ready to fly, and these technologies can be used anywhere in the world for digital adoption in health domain.
Absolutely. It's such a proud moment to know that every line of code that is written in the solutions, digital health solutions developed by CDAC, is written by Indian programmers. Such indigenous solutions going global, going beyond the borders of India is truly what will define the next decade of India into its journey of leadership in digital health. Thank you so much, Praveen ji, for
Thank
this
you.
candid and
Thank you.
insightful conversation. We learned a lot about CDAC and understood a lot about what you're doing, what are the next projects that you're doing. Through platforms like Digital Health News, we are also trying to create awareness about digital health, create awareness about what ecosystem players like CDAC are doing, and what is the role, importance of your role in this entire ecosystem. Thank you so much for this conversation. And for those of our audience who do not yet know, our current initiative is currently ongoing, which is DHN Health Tech Innovation Challenge, and we are really, really proud to have C-DAC as our ecosystem partner for this initiative. And thank you so much for supporting us for this.
Thank you, ma'am. DHN, it's a very nice initiative which DHN is taking. This will definitely help citizens of India to know about what is happening in the digital health. Thank you very much.
Thank you. Thank you so much, sir. Have a great day.
Thank you.